come to the experts' perspective that we are looking on for inclisiran, a novel therapy that has come to change the perspective how we manage dyslipidemia. So let's go and dive into the knowledge of inclisiran and its therapeutic aspects in management of dyslipidemia. If we look at the Indian perspective, Indians have very high CV risk, experience very early CV events. It occurs almost a decade ahead of Caucasians. Elevated LDLs are crucial because of their strong and linear association. We know if we were to plot all the trials in a graphical fashion, what was their mortality versus what was their LDL levels achieved in those trials, you'll find them to have a linear correlation. If the mean LDL achieved, say in trials like VOSCOPS or FCAPS or 4S, was in the range of 130s and 140s, mortality would be around 20-25%. And if you come down to trials like Jupiter in primary prevention, where the mortality was much lower, around 5% in primary prevention, and you were to pull this line down to where it meets to the zero, that would come to roughly 39 or for the primary prevention and around 50 for secondary 50 for primary prevention and 39 for secondary prevention. So for 1 millimole decrease, that is 39 milligram per deciliter, there is 21% reduction in major adverse events in these trials. So the latest guidelines, they recommend strike early, strike strong for intensive lowering. We now even know, the slides are moving. So we now know that the latest guidelines recommend to strike early and strike strong for intensive lipid lowering to achieve the targets. Lower is better, but earlier lower is even better. So we know from the ESC guidelines and the ACC consensus that the clinical ASCVD at very high risk patients, you need to keep LDLs to less than 55 on, this should be at least more than 50% reduction. And even ESC guidelines talks about LDL less than 55 in patients with second event within 2 years, you need to keep it below 40. Even Lipid Association of India is talking about more aggressive lowering. They say the extreme CV risk, probably LDL between reduction to 10 to 15 might be advisable. Also, extreme CV risk category, LDL-C reduction to less than 30, and extreme CV risk category A up to 50, and reduction of more than 30 in optional in these patients. So Indians, the goals are even lower, and hence probably more aggressive lowering is required in these patients. So there is no significant association between any low levels and any safety concerns. So people, when Lipid Association came with 10 and 15, people thought, what if it causes some other side effects of the same? Likely, like, for example, dementia or early Alzheimer's, etc. None of them have been proven true. Even if you look at the serious adverse events, they are lesser naturally because of occurrence of prevention of event rates. A secondary analysis, even the Fourier trial, showed that the benefit of lowering LDL-C, there was no safety concern even below 10 milligrams. So inclisiran is the first in the class of silencer RNA therapy in LDL-C. It specifically works only in liver. It doesn't go and cross any other organ or blood-brain barrier for that matter. It mimics the body's process of interfering with the RNA, and it's restricted only to cytoplasm. It's conjugated with GAL-NAC for the specific uptake for hepatocytes, and hence only liver is the site. There is very low likelihood of any binding outside liver. And inclisiran plasma levels actually decline within 24 hours, and they are not detected at 48 hours, which means completely it is now bound in liver only. So the mechanism is to prevent production of the target protein only with greater hepatic uptake of circulating LDL-C receptors, and hence the LDL-C is cleared from the bloodstream by these receptors. So the Indian approval, as you know, for CDSO would require that it's to be first tested, and the hypothesis has to be and Indian patient data sets has to be approved of, and that's why the right now CDSCO has approved inclisiran in adults with primary hypercholesterolemia, which is either heterozygous familial hypercholesterolemia or non-familial hypercholesterolemia, or even mixed dyslipidemia as an adjunct to diet. Also in combination with statin or other therapies when the patient does not reach LDL goal with maximum tolerated statin, or alone or in combination in patients who are statin intolerant or whom statins are contraindicated. So these together constitute a big subgroup of patients, practically almost everyone, because the target goals are so low that almost everybody is not meeting the criteria on the simple. So inclisiran is suitable for patient profile in which it's useful for high CV risk individuals who have established ASCVD, whose high LDL cholesterol remains inadequately controlled despite standard statins, ezetimibe or bempedoic acid. And it's also useful for heterozygous familial hypercholesterolemia. These are the two strong subgroup of patients where so inclisiran is recommended to be given a dose of 284 milligrams as a single subcutaneous injection initially, followed by 3 months and then every 6 months. So once the 1.5 ml of infusion injection, which contains 300 milligram of inclisiran sodium, which is equivalent to 284 of inclisiran alone, the water with the diluent, and then which is the biggest advantage in these patients, that it can be stored and transferred in room temperature. It's to be given subcutaneous injection in abdomen in healthcare professionals. So the mix, when the dose is given, what to do when the dose is missed, which is very often can happen. It may not be exactly 6 months. If a planned dose is missed in less than 3 months, it should be administered dosing continued according to patient's original schedule. And then a planned dose is missed if by more than 3 months, then you'll have to restart as 0, 3, and 6. So it has to be given 0 and 3, and then you can do every 6, provided you give it within 3 months. Then you need not give the repeat 3-month dosages. Treatment transition from monoclonal antibody PCSK9 inhibitors is what now we are looking to achieve. It can be administered in patients who are already on evolocumab-like therapies after the last dose of the same. And to maintain LDL-C, it's recommended that inclisiran is administered within 2 weeks after the last dose of So the CSI guideline, Cardiological Society of India, recommends in 2023 that management of dyslipidemia, where the patient's non-fasting lipids are within 24 hours of the acute coronary syndrome, has been done. And if you find out that LDL targets are not reaching 55, that's when the target is recommended classically. Or even in those patients where LDL-C remains above 55 after the statins or adding a bempedoic acid, that's when you would choose PCSK9 inhibitor in form of inclisiran or inclisiran in LDL target has to be reached as early as possible, which is repeated at 12 weeks. And then if the LDL-C is still not reached, then that's another subgroup of patient where you'll have. Even the NICE guidelines, they recommend inclisiran in heterogeneous familial hypercholesterolemia in a specialist services, where the scope of the specialist services locally may include lipid clinic. PCSK9 is therapy or FH genetic diagnosis may be required in these patients. But remember specifically that in the by the Simon Broom criteria, if the LDLs are more in the 200, then the patient is anyway suspected to be having familial hypercholesterolemia. In secondary subgroup of prevention, these patients are chosen if the LDL goals are not met on top of the statins as early as 3 months after the adherence to the therapy has been noted. And if the patient is symptomatic, it's recommended. If the statin is contraindicated or is not tolerated, even those subgroup of patients, you need to be choosing the patient. Next, the phase 3 trials are called as Orion series, Orion 9, 10, and 11. There have been series right up to 18. 9 was with heterozygous familial hypercholesterolemia. 10 is with ASCVD, while 11 is ASCVD or its equivalent risk. The dose is remaining the same. The treatment period was in all the 18 months, and the status is completed. The pooled analysis of this shows that there is 50.5% reduction in sustained LDL-C reduction, with effective LDL-C reduction reaching from 50 to 50.7%. And this is a pooled analysis which shows effective and sustained LDL-C reduction with very low inter-individual variation. Irrespective where you are, you'll always end up with nearly 50% reduction to the maximally on top of statin tolerated doses. 68% of the patients will achieve a goal of less than 70, while 52% will achieve a goal of less than 50 LDL on inclisiran. In Asian patients, Orion 18 is the trial. Patients with ASCVD, high risk CVD were associated and analyzed, and placebo-adjusted LDL-C reduction after baseline was again 57.2%. Also, lipolitole, which is a big chunk of a problem, and there are no current therapies except inclisiran, also is lowered by 41% as compared to placebo at nearly 1 year, that is 3. Orion 10 also shows that the inclisiran reduced levels of atherogenic lipids and also improves HDL. The total cholesterol, ApoB, non-HDL, TG, lipolitole, all are reduced significantly with placebo-adjusted dose of 33%, 48%, 47%, 12%, and 25% respectively. HDL is improved by 5%, with inclisiran actually increasing it by 7.5% compared to placebo also having some benefit. Can it be? So it's a well tolerated. There have been 6.8 years of exposure. Orion 8, which is the open label extension of Orion 3, 9, and 10. They have also looked into of 3,274 patient participants were assessed for long-term safety efficacy twice a year in patients with high CV risk, elevated LDL cholesterol. Inclisiran reduced its level long-term, well tolerated, acts in the cytoplasm hepatocyte, not in the nucleus. So there is no risk of carcinogenicity or immunogenicity. So the results of Orion 8, the largest of the long-term safety efficacy trial with inclisiran, have shown inclisiran could reduce LDL in long-term well-being. It's well tolerated, and if you can see, there is 113 milligram per deciliter was the mean baseline LDL-C, and 82.7% of the patients actually enrolled had ASCVD with the results of the reduction in these patients with good safety and with tolerability exposure of 2.6 years of almost more than 8,000 patient years in totality, accounting for wonderful reduction of almost 50% of LDL-C in these patients, with 90% of patients achieving the goal at the end. Inclisiran reduced its level long-term, well tolerated, acts in the cytoplasm hepatocyte, not in the nucleus, so there is no risk of carcinogenicity or immunogenicity. Next slide. So the results of Orion 8, the largest of the long-term safety efficacy trial with inclisiran, have shown inclisiran could reduce LDL in long-term well-being. It's well tolerated, and if you can see, there is 113 milligram per deciliter was the mean baseline LDL-C, and 82.7% of the patients actually enrolled had ASCVD with the results of the reduction in these patients with good safety and with tolerability exposure of 2.6 years of almost more than 8,000 patient years in totality, accounting for wonderful reduction of almost 50% of LDL-C in these patients, with 90% of patients achieving the goal at the end of the study. We will have. So Orion 4 and Victorian 2P are ongoing CVOT trial with completion dates which are anticipated in 2026 and 27. The results of ongoing, the recently published pooled data analysis of 9, 10, and 11 have already shown cardiovascular benefits in with subgroup of patients with inclisiran, 26% reduction in MACE compared to placebo arm, with over 1.5 year with fewer MACE with placebo. Mendelian randomized trials with 20 million patient years follow-up have proven dose-dependent log linear association between absolute magnitude of exposure